that maybe he will bring up, or the two doctors will discuss today, I'm not sure, is sudden hearing loss. That has happened to me on several occasions, and he was able to bring me back alive. And if any of you ever notice that your hearing is slowly going, get to a doctor as fast as your feet can get there. Dr. Stacy Kolb, I'm sorry, I just got the information on her today, so bear with me while I read this thing, even with my shaky hands. She recently graduated from the University of Arkansas, and I guess this year, and got her degree in medical sciences there. Last year she went to the Orange County, or she became affiliated with the Orange County Physicians Hearing Services. They and the Head and Neck Associates go hand in hand. And she is on a program, I've never heard of this before, externship. I always thought it was internship, but she can explain that a little bit better. And is in the process of, I'm sorry if I have to read this, getting her license as a fellow of the American Academy of Audiology. So with this brief introduction, let me introduce Dr. Wilgemuth and Dr. Kolb. It's a pleasure to have you here both. Let's give them a big hand of welcome.
All right, I'm going to stand over here because this is the only way that we can change the slides. So yes, I'm Dr. Stacy Kolb. I just graduated in May of this year. So I'm officially a doctor. The way our program works, if you've never had an audiologist or had someone explain to you, is it's 4 years. So it's a doctoral program, 4 years. The last year is an externship, what they call it. You can basically compare that to a residency that maybe a doctor would go through, or just, it's basically full-time work, still as a student, but it's after that we become a doctor. So I just completed that, and now I've been hired on to work at Orange County Physicians Hearing Services, which is just about 10 minutes from here. So today I wanted to talk to you guys about hearing technologies, all the different types and styles. Maybe some of you wear hearing aids and you've heard of a cochlear implant, but you're not quite sure what it does or how it works, or maybe you've worn a cochlear implant and you don't know about what a bone-anchored hearing aid does. So I'm just kind of here going to explain a little bit about all the different technologies for you. So there's basically 5 hearing technologies, and I have examples of all of them. I can pass it around. So you have the traditional daily wear, and also extended wear hearing aids. So you probably all know what these look like. You have the different styles behind the ear, or the custom style like this that just goes right into the ear. Then you also have the extended wear, the lyric, and we'll talk about these more in depth. This is the type that just kind of lives in your ear for a while and it gets replaced. We can pass that around because it's kind of interesting to look at. And this is the device itself right there.
Excuse me, is your microphone on?
Sir.
We can't hear you.
Sir.
Can you hear me now? Oh, sorry. Can you hear me?
You have to kind of speak a little louder.
Okay. So the next one is the middle ear hearing aid implant, which is a surgery to implant a hearing device into the middle ear. The third one is the bone-anchored hearing aid, which is also a surgery. And then the fourth one is a cochlear implant. I've seen a few in this room already. And then the fifth and final is the auditory brainstem implant, which functions sort of like the cochlear implant, but we'll talk more about that. So before we begin, we'll just go over some basic ear anatomy, just so you can kind of touch base with each of the structures and know what each hearing aid does. So you have the outer ear here, which is called the pinna, the external auditory canal, which leads to the eardrum, which is made of 3 layers of skin. Connected to the eardrum, you have the middle ear bones, the malleus, the incus, and the stapes, and they are all connected to the cochlea. And we'll talk about how sound is transmitted through the ear to the brain as well. So in the cochlea, which is this snail-shaped structure, you also have the semicircular canals. Those are these 3 rings here. And what these do are they control the balance. So if you've ever heard of someone with a disorder called BPPV, benign paroxysmal positional vertigo, what it is the crystals that kind of live in the cochlea, they kind of get dislodged and start roaming around these little canals, and it gives the sensation of vertigo. So that's where that happens if you've ever heard of BPPV. Now, these fibers here are connected to the auditory nerve, which runs onto the brain, and that's all connected within the cochlea. So you have your outer ear, your middle ear here, and the inner ear here. So the way that sound, I feel like my voice is better this way, but I'm not sure. The way that sounds are transmitted through the ear to the brain is they enter the outer ear and they travel through that ear canal, and that leads to the eardrum, which vibrates for the incoming sounds, and it sends the vibrations to the 3 small bones in the ear. And those bones basically amplify or increase the sound vibrations, and that sends to the cochlea, the snail-shaped structure. And the cochlea is actually filled with fluid, and so there's an elastic partition that basically runs through the cochlea, and on top of that partition sits the hair cells. You've heard of maybe your audiologist or doctor saying, oh, the hair cells in your cochlea are damaged, and that's what's causing your hearing loss. So they're sitting on top of that partition in the middle, and basically they kind of ride the wave of the fluid that is running through the cochlea. The middle ear bones press into the cochlea, and they move the fluid, and that moves the hair cells. And eventually the little pieces on top of the hair cells open up, chemicals kind of flow in, and that creates an electric signal, and it carries that to the brain. It's kind of a complicated process. I know before I got into audiology school, I didn't realize all the things that are happening in a split second when you hear something. So, does that make sense so far? Any questions? Everyone can hear me, right? Yes? Okay. All right, so I'm sure you've all seen an audiogram too. I just wanted to put that up here just in case. Frequencies are across the top like a piano. Loudness or intensity is down this scale. Soft sounds to loud sounds. Normal hearing, followed by mild, moderate in the middle, severe, and profound. And this right here is what we like to call the speech banana. So it houses all the sounds that we hear in daily speech. The vowels and the sounds like M and N are on the lower scale. The sounds like F, T, S, P, I'm sorry, P is over here, but S, T, F, T is what I was saying, is on the higher scale. So if you have a hearing loss, like most people do, this is kind of a common type that goes like this, ski slope is what we call it. You're missing all these sounds here in the higher frequencies. So that's causing that perception of being able to hear, but not being able to understand.
Oh.
So there's 3 types of hearing loss. Sensory neural, which is the most common, conductive, and mixed. Sensory neural is caused by damage to the inner ear, to those hair cells, or to the nerve pathways from the inner ear to the brain. Most of the time, it can't be surgically or medically corrected. And some common causes of sensory neural hearing loss are maybe illnesses, possibly drugs that are toxic to the system, like a lot of chemotherapies are toxic, possibly genetic causes, so it may run in the family. Just in general, aging and exposure to loud noises, malformations of the inner ear from birth, or head trauma. So conductive hearing loss That's the next type. It occurs when the sound is not being conducted through the middle part of the ear. So where all the bones are right here, not being conducted correctly. And it involves basically just a reduction of the sound in general. And so a lot of times this type of hearing loss can be surgically corrected. And some possible causes of the hearing loss include ear infections, maybe fluid in the ear, allergies, a perforated eardrum, so a hole in the middle ear of the eardrum, any kind of tumors growing in the middle ear, impacted earwax, any other infection of the outer ear like swimmer's ear, or any just malformation in general. And then the third type is mixed, which obviously is just a combination of the two. Maybe someone has sensory neural hearing loss from noise exposure, and they also have a conductive loss, from maybe from a surgery or something like that. So mixed is both. So first let's talk about the daily wear hearing aids like these that I showed you. The standard kind of behind the ear type, or the not the conductive, but the custom type. So basically these hearing aids are taking sounds from our environment, acoustic sounds, and through a series of algorithms in the chips and the circuit inside the hearing aid, they're amplifying it for only the select frequencies that the wearer needs. And the sounds are presented just like all sounds would, through the eardrum, being conducted through the middle ear into the inner ear. And hearing aids can help people with mild hearing loss all the way to profound hearing loss. So there's a pretty wide range that hearing aids can help. And like I said, there's all different styles, custom, receiver in the ear, behind the ear. They all basically do the same thing, but the acoustics and the power capabilities are different. So a hearing aid like this tiny little guy, couldn't do the same power capability as one like this. So it just depends on what kind of hearing loss. And then the second kind of the hearing aid is what I passed around, the lyric. So basically this hearing aid kind of stays in the ear for 6 to 8 weeks until the battery dies. And only an audiologist or someone qualified to remove and insert these devices can do it. Most people aren't a candidate for this type. There is an output limit, so someone with a severe to profound hearing loss may not benefit from this type. Also, different ear anatomy can make a difference. So some people like me have tiny ear canals, probably not going to work for that type of hearing aid. And then, people who have constant drainage or maybe a lot of wax, not going to work for that either. So it's a very select population who can benefit from those. So the second type is the middle ear implant. This is called the Esteem, and it's a surgically implanted middle ear device. The idea closely resembles that of a normal hearing aid, but it's all inside the head, so nothing to wear on the outside. It's best for people with moderate to severe hearing losses. So let me just explain how it works. The sound enters the outer ear as it normally would and funnels down the ear canal and causes the eardrum to vibrate. So basically, then the sensor, which is this piece right here, it picks up those vibrations, sends it to the sound processor, which would be somewhere in this area, surgically implanted. The sound processor kind of takes all the information and amplifies things as they would need to be amplified for the person, and it then sends it down back to the driver. And it looks like it's kind of connected right between the incus and the stapes, those two bones in the middle ear, and basically gives the hearing aid user what they would need. So kind of an interesting idea, not really feasible for everyone. It's a pretty expensive surgery, but for someone who's really concerned about cosmetics or things like that, it's a good option. All right, so next is the bone anchored hearing aids. I brought a little display here, and I'll tell you how it works. This is best for people with that conductive hearing loss, when the middle ear is not working correctly and they just need a little boost. It's also good for mixed hearing losses, so they may have an element of sensory neural hearing loss as well, or for someone who has single-sided deafness, so one ear, just no hearing at all. So what it is, it's a titanium rod that's surgically implanted into the skull, and it basically osseointegrates or grows into the bone. And you have an abutment that attaches on to the skin outside. It's just like a little button. And basically it snaps on, just like that. And I'll pass that around too. So they've recently come out with a magnetic option to where you can have a magnetic disc instead of the abutment, and then the device just magnetically attaches. So the way this one works is the sound processor, the little piece that I just snapped on, picks up the sound vibrations from the environment, and they're transferred to the abutment to the small titanium implant that's inserted into the bone. And those sound vibrations are sent directly to the cochlea because the cochlea is housed in bone. So there's no really amplification needed unless you have that mixed hearing loss. And they're converted into electrical impulses by the hair cells as it would normally happen. So a small select population can benefit from the BAHA, but it's a very interesting and neat device for those people who need it. Okay, so the fourth one is the cochlear implant, and these help with people who have severe to profound hearing loss who just are not getting enough amplification from the traditional hearing aid. So it's a device that actually provides direct stimulation electrically to the auditory nerve in the inner ear. And it requires an extensive surgery to implant the electrode array into the cochlea. And those electrodes stimulate the fibers of the auditory nerve. So I have this really neat diagram here of how it all works. But let me just, okay. So basically, a magnetic piece is inserted into the skull, and along with that magnetic piece, I don't know if you can see this very well, but there's an electrode array. And basically the cochlea is snail-shaped, and so they insert that electrode array into the cochlea and it curls around the cochlea. That way it can stimulate different areas of the cochlea. So the microphones, again, pick up the sounds in the environment and it converts them to a digital signal. And then that is transferred through the coil to the implant. So microphones here pick up the sound, transfer it to the coil, which is right here, and then magnetically that is transferred to the processor underneath the skin and the skull. And from the processor, it's all processed according to what the wearer needs, how severe their hearing loss is, and it sends electrical signals into the cochlea, which then fire to the brain. So I can pass this around too. There you go. And feel free to take it on and off the ear, it's kind of fun. So the last one we'll talk about is the auditory brainstem implant. Most people don't really know about this one. It's a similar premise to the cochlear implant. In fact, it looks exactly the same, as you can see in this picture. But it treats a specific type of hearing loss that only a select few people have. So it was specifically developed for people who maybe their cochlea is malformed. A lot of people with meningitis, their cochlea kind of turns to bone and no longer can provide that sound. But it's basically made for people who have NF2, neurofibromatosis type 2. So let's talk about what that is for just a second. Basically, it's a lot of benign tumors growing on the vestibular branch of the auditory nerve. Now they are benign, so they're not cancerous, but as they grow, they can produce life-threatening symptoms, pushing on different parts of the brainstem or the brain, and it can just turn out not so good unless you have it surgically removed, but in that case, surgery often damages the hearing. So basically what this device does is instead of inserting the electrodes into the cochlea, the electrodes go to a part of the brain called the cochlear nucleus, which is responsible for, it's basically at the end of the auditory nerve, and it's responsible for the incoming signals in that area, and that is processed in the brain. So instead of stimulating the cochlea, it's stimulating the actual place in the brain where the auditory fibers go. So like I said, not a lot of people can benefit from this, but it's very, very interesting and groundbreaking technology for these people who have lost their hearing due to different things like NF2, the ossified cochlea, or maybe they even have an absent auditory nerve from birth, or one that's not functioning very well. So, thank you so much for listening. I hope you learned a little bit. Maybe you learned about something that you didn't know before. So if you have any questions, you can ask now or after Dr. Logan. Yes?
Are any of these surgical implant procedures covered by the Medicare supplement insurance?
That's a good question. I worked in Arkansas, like George said, I worked at a children's hospital in Arkansas in Little Rock, and we service mainly children, a lot of children who got cochlear implants, but we serviced a lot of adults who got them too. And I know they were covered. I'm not sure what they were covered by. Does that make sense? So it could have been, I feel like it was Medicare, but I am not the expert on insurance. I'm not sure if it also differs state to state. Okay?
Can you go swimming or shower with some of these,
Yeah.
with all of them?
Let's see. Obviously, no swimming with with hearing aids. For Baja, absolutely. You just take it right off.
Oh, yeah.
And cochlear implants and auditory brainstem implants too. However, cochlear implants are now waterproof, so you can put them in this little case, and basically it's for kids at the pool who want to hear and play with their buddies while they're swimming. It's been developed for that. But other than that, especially, these live in your ear, right? So you can shower with them. Just try not to get them too wet. Yes.
Yeah, let me just use the microphone.
The other one's dead. So Med-L is another cochlear implant company, and they have water wear for both their
Yes.
Rondo and their processors,
Yes.
so they can go
And
swimming.
cochlear does too.
Yeah.
Yes. Thank you for adding that. So, and yes. Any other questions? Okay. Looks like it's Dr. Williams.
Your paperwork's up there too.
I think there were some handouts on the sudden hearing loss,
Or
George?
in the back.
In the back. So on the back table, not any, I'm sorry, you shouldn't do that in the microphone. I've done this as much. It's nothing that, it's not the notes for my talk. It's just supplemental things. And also here's a handout on earwax that I was asked to comment on. We can start that quickly and end it rather quickly. Wax is something we produce normally. It has a positive function in terms of preventing infection in the outer ear canal. Some people make too much wax. Some people have small ear canals, and a normal amount of wax will block the canal. But the bottom line is, earwax obstructs the outer canal, as Dr. Kolb showed you there. So if you have earwax, then the sound cannot reach your eardrum, whether it be with a hearing aid or without a hearing aid. So how do we keep it clean? You can use a Q-tip. I suggest if you're using a Q-tip, grab the Q-tip right where the cotton ends, and that's where you're holding it, and you can go that deep. So you're not going to shove your thumb through your ear, and you can go to town with that and shove it. You don't have to be awake. As long as you're holding on, you're not going to do anything bad. because it's only going to go in the cartilaginous or soft part of the ear canal. Beyond that is the bony part of the, can everybody hear me? The bony part of the ear canal, that gets very, very tender, and you go down far enough, you hit the eardrum. So you have to kind of be brain dead to puncture your eardrum. Has anybody done this here? Puncture their eardrum before I insult you again? No? Okay. I've had 2 patients who've done that. One had a Q-tip in her ear, and she was cleaning, and someone startled her, and she shoved it in. The other, she had the Q-tip in her ear, the phone rang, and it did it that way. So it really hurts. Long before you get to your eardrum, it's very sensitive. The Q-tips aren't made to reach the eardrum. You can get down there if you're careful, and if your ear canal's a little tight, pull your ear up and back like Spock, old Star Trek days, and the ear canal, instead of pointing forward and down, you pull it up this way, and now it's a straight shot. So when I'm looking at someone's ear, I don't even think about it. My thumb or one of my fingers is going here to pull the ear back up here. So on this side, it's at 10 o'clock, and over on this side, it's at 2 o'clock. And that straightens the ear canal out if you're having trouble getting things out. What I suggest, if you're use your wax catcher on your hearing aid. That does help. If you have a frequent hearing aid problem and your doctor says it's not because of an abnormality in the ear canal that he or she needs to treat, where we look at it under the microscope, then there's no reason why you can't keep your own ears clear and avoid us and not need to come in. And that's just a matter of when should somebody clean their ears the day before it plugs up. So you don't really know when it's going to plug up. So it's just better if you do it on a schedule. So you kind of figure out what works for you. If people are coming to see me, if they come in 4 months and they're plugged, they came in too late. So they come in 3. If someone comes in 6 months, I mean, it's just, I had one guy who was coming in once a month. He had narrow ear canals and just he'd get plugged up. So the bottom line is just set a schedule. I suggest, one suggestion, first of the month, pay your bills, flush your ears. It's easy to remember. And then the instructions here, there's several kits that are over the counter. Debrox, Ceruminex, Murine, they're all the same. They're all ceruminolytics, which is just a chemical that takes solid wax and makes it jam. Jam's very difficult for us to get out of there because we can't really grab it and pull it out, or it's hard to suction out because it's just pasty. So if you do that, then you get the bulb syringe, the rubber bulb syringe like you use for the babies, and fill it with tepid water. If you really want to game it, you can throw a little bit of alcohol in there too that helps dissolve the wax a bit and dry it up. And so when we do it in the office, I do about 4 parts water, 1 part alcohol. And then flush it out after you put the drops in, flush it out. If the water is too cold, you're going to get vertigo. You set up what we call an ice water caloric that Dr. Kolb knows all these things about, because now that she's a real doctor, she's really much smarter. Now, Stacy's been great, and thank you for coming here. I know I kind of put you on. I put her on the spot, but I thought, come on, I have to be the one that gets a chance to be there on the same stage as her when she first time as a real doctor. Because I was there early on when she wasn't, and some of our patients gave her a hard time, and I made sure they didn't do it a second time. So we all had the title instead of MD, AUD, AAD, almost a doctor. You gotta start somewhere. That doesn't mean someone said to my father when he was practicing, said, "You look so very young." He goes, "But I'm very smart." So obviously Stacy's very smart, otherwise she wouldn't be doing what she's doing, and also we wouldn't have asked her to stay on with Physicians Hearing Services, which is the hearing extension of our practice, and excellent audiology care, all doctoral audiologists, very well trained, and just a good group of people, really nice people, really smart, all the resources, honest, integrity. You don't get that everywhere. I mean, you don't have to worry if you're trying to be oversold. So go wherever you can go wherever you want for the hearing aid needs. You'll get a slightly better price at Costco or something like that. So if you have a bread and butter hearing loss, go for it. I think it's appropriate, but it's different and it's not the same for people who have more complicated problems, and there Our audiologists are all over it, and we're steps away if there is an infection or a problem that we need to jump in on, where you go and think it's your hearing aid, your instrument, and it's really your ear that's a problem, a fungus or an infection. And so you don't have to go make an appointment. You just 20 steps and you're in our side of the office. So back to the earwax, if you just flush it out on a regular basis with the warm water, and that's it. You know, once it gets clear, the alcohol will help dry the ear canal so this wax, the water doesn't get retained. Any surfer dudes here? Anybody used to surf? Anybody hop on a surfboard ever in their life here? Oh, come on. Goofy or regular? Goofy or, no, you, are you goofy or regular?
No, I'm a
Regular,
Regular? Did you surf a lot?
No,
Okay.
But our son surfs all the time,
Yeah.
and he's starting to grow.
Wait, and is he regular or goofy?
He's
Goofy.
regular.
Well,
Is he goofer? Oh, goofy.
he's goofy? Okay, that means he takes lefts. When you come down the wave and you want to go to your left, that's a goofy foot. Regular foot goes to the right. The reason you ask is their son, his left ear is going to be more blocked up with bony growths. Not 100% of the time, but it's pretty consistent observation because it's a cold water phenomenon. If you've heard of surfer's ear, the cold water gets in their ear, and if someone who's an avid surfer is in the water a lot, and earplugs are just not something you wear because then you can't hear what's going on, so they get these bony growths in response to the cold water, and that traps wax. So I've got 2 people now that I'm treating, trying to get their ears opened up because there are these bony growths. So they've got a narrow canal. Sometimes you're born with a congenital small canal, just a tiny little ear canal. It's not a problem, it's just you're special and different. You just need to deal with it more. But you really don't want to wait until your ears are plugged and then you have to call and make an appointment. Because the reality is when your ears are plugged, you're not hearing. If you're not hearing, you're missing things. And we're all in the same boat. Our afternoons to enjoy are finite. At the end of the day, you're -1 and you don't get a +1 down the line. So you got to make the most out of each day and get the best out of what we have. And that's what we try and do with hearing. So that's kind of long-winded. Any questions on earwax? Yes.
Well, I need to, it isn't earwax, I need to know if you have any patients that have had their hearing damaged by drugs, like aspirin.
Aspirin specifically is ototoxic, but it's irreversible. It is reversible. So the ringing you get from aspirin, as soon as you stop the aspirin, the ringing goes away. There are other drugs that are ototoxic, certain antibiotics, it's called like gentamicin or aminoglycosides are the notorious ones, several chemotherapeutic agents that are ototoxic. So my advice on that part, if you're getting, always make sure you have a baseline hearing test. Somebody comes into me for whatever. If they're over 50 and they haven't had a hearing test, they'll get a hearing test if they have time, because to get a baseline EKG, you need a baseline audio, because when we talk about sudden hearing loss, how do I know if you have a sudden hearing loss if I don't have a baseline? So you always want to get a baseline. My 2 other soapboxes, 50 colonoscopies, right, everybody? And any of you that have adolescent boys in the family somewhere, make sure